reduce all-cause deaths and also the cardiac deaths more than 40 to 50%. So we always say that the IVUS saves lives in layman PCI. And of course, I know that IVUS is not a cheap device compared to our wire or guiding caster. But since that a lot of studies can prove that the IVUS guide can reduce the mortality, I would recommend, if possible, to use IVUS in every layman PCI case. So in the ESC guidelines, the IVUS for layman PCI was a 2A indications. But here you may wonder that since we got a lot of evidence, why it's only 2A, but it's not class 1 indication? Well, it seems to me that because most of these IVUS in layman PCI clinical trials are only retrospective study or some registry, and all of this were not a prospective randomized trial. I think that maybe it's the reason that the indication for the layman PCI of IVUS is only 2A but not class 1. And here is my tip and tricks for the IVUS usage in layman PCI. Well, the first one is I would recommend to wire both LAD and circumflex before you do the intervention, and use your IVUS to pull back from each branch all the way back to the aorta, not only LAD, but also the circumflex. And in the next slide, I will show you an example. And I also recommend to do the predilatation in case of tight layman stenosis. You should know that the automatic pullback of the IVUS was only pull back the probe inside the protective transparent sheath. Even your probe is already back to your guiding caster or in the aorta, but the transparent sheath is still wedged the tight stenosis. So the hemodynamic status will be compromised. So I would recommend, if you face tight layman stenosis, please do the predilatation first and then do the IVUS pullback. And the next one is I would recommend to coaxial positioning of your guiding caster tip. And of course, it's the basic that you have to do the IC intracoronary nitrate injections and then disengage your guiding caster from layman ostium, that you can have the whole picture and also the layman anatomy all the way back to its orifice. And I also strongly recommend always use the automatic pullback at a speed of 0.5 millimeter per second, unless, as we mentioned, that tight lesion without predilatation. In such case, without predilatation, I would recommend to use the manual pullback first. But if you already do the predilatation, you can easily to do the automatic pullback, both from LAD and also for the circumflex. And of course, if you are still interested in some spot, after the automatic pullback, you can use the manual pullback afterward. And then please increase the image depth to the maximum, because sometimes the layman was quite huge. And the last one is the oblique transducer position may create an artificially larger layman minimal lumen area when turns from greatest angle branch, and usually it was the circumflex. Here is the example, as I mentioned before. In the upper panel, you can see it's the LAD pullback of the layman bifurcation lesion. In the red box, you can appreciate that the LAD ostium is quite diseased, but from this projection, you can appreciate that the circumflex ostium seems clear and disease-free. But in the lower panel is the circumflex pullback, and you can clearly appreciate that the circumflex ostium is not disease-free. Instead, the plaque burden is quite huge, up to 81%. And on the other hand, you can appreciate that the LAD ostium from this pullback seems clear and is quite different from the LAD pullback as we show in the upper panel. So I mean that we are not only doing the LAD pullback to survey the circumflex ostial lesion, and I would recommend to use the IVUS pullback both from LAD and also from the circumflex. Okay, here is some decision steps in layman PCI, such as to treat or not, how about the stent strategy, how about the risk of circumflex gelling, and how about the device sizing, and how to optimize. And I think these critical steps can be answered by our IVUS. And first, we just talk about the treat or not. In our previous presentations, even it's not in English, but I can appreciate that the same studies. And this is more than 16 years ago. It's the IVUS cutoff value published by Dr. Justy from United States. When it correlated with the FFR 0.75, they conclude best sensitivity and specificity for the IVUS cutoff value for lemon stenosis is 5.9, and we can roughly say 6 millimeter square. And this value was also validated by another study called the retro study. And this study was published 10 years ago in JACC. It's an intermediate lemon study, which demonstrate that in such an intermediate lemon lesion, they defer the patient if the lemon minimal lumen area more than 6 millimeter square, but they do the revascularization no matter by CABG or PCI whenever the patient have the minimal lumen area less than 6. And you can appreciate that after these two randomized study, the revascularization group and the defer group have a similar clinical outcome, which means that the 6 millimeter square value was validated for this literal study. And also in the previous talk, we also mentioned another similar study published by S.J. Park about 7 years ago. And the similar study, but different population, they conclude the cutoff value is no more 6, it's 4.5 millimeter square, and it's almost equal to the minimal lumen diameter, only 2.5. But what's the difference between the Justy value of 5.9 and the Park value 4.5? Well, here is the comparison that the published year is quite different and it's 10 years apart. And Dr. Justy used 55 Americans for his study, and Dr. S.J. Park used more than 100 Korean patients for his 4.5 value. And the cutoff FFR value was also different. Dr. Justy used 0.75 and Dr. Park used 0.8. And the baseline FFR is also different, which means that the patients from Dr. Park's group is a little bit more severe. And also for the hyperemia by adenosine is also different. Dr. Justy used the IC adenosine for the hyperemia, and Dr. S.J. Park used the IV continuous adenosine for the hyperemia. But on the other hand, Dr. Justy's 5.9 millimeter square value was clinically validated by the literal study, as we mentioned before. But Dr. Park's value 4.5 was not validated by any clinical studies. But in conclude, in the ESC experts consensus, they just conclude that no matter how's the minimal lumen area, if we encounter the minimal lumen area less than 4.5, we should do the revascularization, no matter by IVUS, by PCI, or by the bypass surgery. On the other hand, if we encounter the minimal lumen area larger than 6, we can safely defer the case for further intervention. And in between, when we have the intermediate lesion that the minimal lumen area of lemon was between 4.5 and 6, we should now go for physiological assessment, such as FFR, as we discussed in the previous section, or by the other resting indexes. And the next question comes to how to treat. I mean, use 1 stent or 2 stent, and we are just talking about how about the risk of the circumflex compromise if we just do a single stent crossover. In the ESC guideline for the revascularization, the provisional stenting is the recommended as a class 1 indication. And also this year in the European Heart Journal, they published the EBC main study. I also browsed the agenda. I believe that this early morning we also discussed about the EBC main study compared to the upfront dual standing for the lemon bifurcation. The provisional strategy numerically reduce the clinical event and significantly reduce the procedure time and also the radiation exposure. But on the other hand, even though the provisional standing strategy was recommended, but by IVUS pullback, if you have this kind of, we call it eyebrow sign, please look at the figure B. It's the spiky appearance of carina by IVUS longitudinal pullback, and it just look like the eyebrow. When you have this eyebrow sign, it's a relative higher risk for the circumflex osteocompromise whenever you do the one single stand crossover. I mean that if you have this kind of eyebrow sign, you should pay attention for the circumflex protection, no matter by only wire or by the balloon cushion or by the upfront two stand strategy. And additionally, if we have the IVUS pullback and evaluate the calcified plaque opposite to the bifurcation, there is a higher risk for the circumflex osteocompromise, especially the calcium arc is more than 60 degrees. In these pictures that you can clearly appreciate that only by stand crossover, you cannot easily just push the calcified plaque away. Instead, after stand crossover, the carina will be pushed forward to close the circumflex ostium after standing when we have this kind of calcified plaque opposite to the bifurcation. So I would say that if you encounter this kind of calcified plaque opposite to the bifurcation, you should pay more attention for the risk of circumflex ostium compromise after standing. And here is the definition criteria for the Lemon bifurcation published by Dr. Chen from China. And they classify the Lemon bifurcation as a simple lesion or complex lesion. Once the osteo lesion is the length of osteo lesion is less than 10 millimeter, and also the diameter stenosis less than 70, they just classify this kind of bifurcation as a simple lesion. On the other hand, if the osteo lesion is longer than 10 millimeter and also the diameter stenosis greater than 70%, plus any two of these minor criteria, such as thrombus content or small vessel or very large bifurcation. If we have more than one major criteria plus two minor criteria, they classify it as complex lesions. In simple lesions, no matter you use two stand strategy or provisional single stand strategy, the outcome was not quite different from each other. On the other hand, if we encounter the complex lesions, using the provisional standings may have the numerical more clinical events compared to upfront two stand strategy. So in conclude that when we have this kind of complex Lemon bifurcation lesion classified by the definition criteria, we may consider upfront two stand strategy instead of the EBC recommended single stand strategy. On the other hand, when we have the simple lesions such as the circumflex ostium diameter less than 50%, we can simply just do the single stand crossover. But after the single stand crossover, in some cases, such as maybe up to 40%, you may have the angiographic gelling, which means that the diameter stenosis from less than 50% and then now up to more than 50% after single stand crossover. But luckily, by the FFR studies, only 7 graphically the ostium seems very stenotic, but only 7% can have the functional gelling. On the other hand, when we have the osteostenosis more than 50%, it does not mean that we have to do the upfront two stand strategy. Instead, when we have the circumflex osteo angiographically more than 50% stenosis, we should evaluate the circumflex ostium burden, the plaque burden by circumflex IVUS pullback. So if we have the circumflex minimal lumen area smaller than 3.7 millimeter square before single stand crossover, or the plaque burden larger than 56% before stand crossover, we may have a higher risk for the functional gelling after single stent crossover, which means that if we have the IVUS pullback, even the diameter stenosis is larger than 50%. If we have the lumen area larger than 3.7 and the plaque burden less than 56%, you may try to use the provisional stand-in first, because the risk of circumflex functional gelling will be not so high. And therefore, the IVUS circumflex IVUS pullback can reduce unnecessary upfront two-stent strategy, and also can determine the optimal device size if we are going to do the two-stent. And now we turn to the device sizing. I think it's the basic job for the IVUS. So after single stent crossover from LAD back to LAMEN, the mechanism for the circumflex stenosis should be the carina shift, because the circumflex ostium minimal lumen area was decreased after stent crossover, and the EEM area at the minimal lumen area side also significantly decreased. Instead, the EEM eccentricity increased after stent crossover, which can translate into the general mechanism for the circumflex stenosis after single stent crossover should be the carina shift, but not the plaque shift. So here is the EBC recommended distal sizing strategy for the LAMEN bifurcation. We use the distal sizing, usually it should be the LAD. No matter by EEM sizing strategy or by the lumen strategy, we use the LAD for the sizing. As I showing here, since that we use LAD for our sizing strategy, that the carina shift risk was not so high, but instead the proximal segment, especially in the LAMEN, should be male opposed. So we have to do the subsequent post dilatation of mid and proximal stent. And please be reminded that we have to left at least 8 millimeter stent in your LAMEN in order to do the pot, because usually we have the shortest NC balloon for the pot is 8 millimeter NC balloon. So please left 8 millimeter stent in the LAMEN for the further pot procedure. And also you have to pay attention for the stent expansion limit, since that we frequently use the long stent such as 30A or 40A stents. So if we just only put like a 2.75 stent from LAD back to LAMEN, but it cannot expand to 5 if we have a huge LAMEN. So you have to pay attention about the stent expansion limit. So I print this chart and pass on the wall of my CAS lab. And before I do the LAMEN bifurcation stenting, I always check the expansion limit for each the contemporary stent design, such as the expansion limit should less than 4.5 if we just use the stent size less than 3.0. And now, after two stent strategy, any under expansion may translate into a future in-stent restenosis. In the previous talk, we have already mentioned that the famous 5, 6, 7, 8 criteria after two stent LAMEN stand-ins. And I think everyone should not so familiar with the area, so I just calculate for the diameter. Everyone should be more familiar with the diameter limit. So the 5 millimeter square area at the circumflex ostium can be translate into minimal stent diameter about 2.5, and the LAD 6 should be translated into 2.8. And the LAMEN 8 millimeter square should be translated into minimal stent diameter 3.2. And recently, there is another clinical trial called EXCEL. It's the PCI versus CABG for the LAMEN intervention. And they did a similar analysis for the relatively Caucasian patient, should be the larger person. The value is no longer 5, 6, 7, 8 as we show in the Asian relative small persons. The number is no longer 5, 6, 7, 8, but 6 in the circumflex ostium, 7 in the LAD ostium, and 10 in the LAMEN ostium. I would say that if we have the bigger, larger patients such as 40 or 50 years old gentlemen, you should use these larger criteria 6, 7, and 10. Instead, if we encounter some small ladies or old gentlemen with a small body size, you can still use the 5, 6, 7, 8 criteria for your final optimization. So finally, if we are going to do the lemon to treat or not to treat, I would recommend the ischemia base. If you are not using the FFR, you should use the minimal lumen area cutoff 4.5 millimeter as you will cut off to do the revascularization, no matter by PCI or bypass surgery. And for the standing strategy or the risk of circumflex gelling, by the EVC recommendation, single stand is better, such as the provisional standing strategy. But on the other hand, if by the IVUS evaluation, if you have the eyebrow sign or have the calcified plaque opposite to your bifurcation, or the circumflex minimal lumen area less than 3.7, and or the plaque burden larger than 56%, or the definition criteria for the complex lesion, you may consider upfront two-stand strategy instead of the provisional standing, because the circumflex ostium compromise is quite high. And finally, we come to the device sizing and for the optimization. I would say that the larger, the better. And for the distal, for the strategy, I would recommend to use the distal sizing as EBC recommended, then do the pot, and to finalize the stand outcome by the famous 5, 6, 7, 8 criteria. So, Mr. Chairman, ladies and gentlemen, here is my conclusions. IVUS is the must tool in current PCI era, especially in the lemon PCI. It's not only reduce the clinical outcome, but also reduce the patient's mortality, and it's also recommended by the clinical guidelines. And the minimal lumen area less than 4.5 millimeter square is represent significant FFR less than 0.8 in lemon lesions. And one stand crossover is indicated if eyebrow side negative, circumflex stenosis less than 50%, minimal lumen area larger than 3.7, plaque burden less than 56, or the simple lesion by definition criteria. And finally, after PCI, the minimal stand area after two-stand intervention should be at least 5, 6, 7, 8 rules, which can predict future outcomes. And I'm welcome any comment or discussion about this topic. I'm Chia Pin Lin from Taiwan, and thank you for your attention.
Thank you, Dr. Lin, for a very practical and scientific presentation. May I invite the panelists for any comments or discussion?
Okay, thank you so much for a very excellent presentation on the role of the IVUS in the lemon PCI. I think the IVUS is one of two IVI, intravascular imaging. It means we have a pole of a technique, IVUS and OCT. So may I ask you about, in your center, you have a pole of the technique or only one? And can you give your opinion when you compare the role of the OCT and IVUS in the lemon PCI, Dr. Chia Pin Lin?
Thank you very much. It's excellent questions. That I would say that the lemon is not a contraindication for OCT. Of course, in our center we have the OCT facilities but sometimes in the huge lemon, and you should know that the basic principle for the OCT pullback, if you are going to have a very good OCT quality, you have to clear the RBC completely. But if you have some huge lemon, it's quite difficult, no matter by the huge guiding catheter or by the auto injectors, it's quite difficult to clear all the blood completely from lemon. So sometimes in such a huge lemon, you cannot have a very good image quality by OCT pullback. And another issue is we always like to check the lemon osteo anatomy, and also for the sometimes after the standing you have to know that how about the opposition of your stent. But unfortunately, by the OCT, you have to deep engage your guiding catheter in order to clear the blood. So usually, I will not say always, usually you may have some difficulty to clearly evaluate the lemon ostium. So in my opinion, I think more than 90, maybe 95% of my lemon PCI, I use IVUS. I use IVUS. So if the lemon ostium is quite okay, and I'm not going to stand all the way back to the lemon ostium, and also the lemon size is not huge, of course, in this case, I may select OCT for my intravascular image guidance for the PCI.
Okay, thank you so much. And we would like to hear some comment from the panelists. Please, Professor Nguyễn Ngọc Hoàng.
Thank you for the great talk, Lee. We just want to ask you how to use IVUS to optimize when you choosing the style of the stand for the left main. Can you give some tip and trick for that? Thank you for that.
What you mean? What kind of stand? You mean the any brand?
The stand design? Yeah. No. I mean stand design, and then how to optimize based on the IVUS finding.
Yes, thank you for the questions. And just as I mentioned that when we do the lemon PCI, we should the critical step is to decide the device sizes. If you are going to have the huge lemon, you have to know beforehand that how about the stent expansion limit of your stent. So in some stent designs that maybe have 3 links, sometimes the span expansion limit should be not so huge enough. So in that case, you may just use another two link stent design for the huge lemon expansion. But I would say honestly that I think according to the literatures, I think the contemporary drug-eluting stent should not have a big difference between each other. I think the critical issue for the future event is not the stent design per se, but also how about the pre-intervention evaluation and how perfect you did the lemon PCI. That should be my answer.
Yeah, thank you for the your comment and answer. Yeah.
Any other comments from the panelists? If there are no more questions, should we move to the left case? Chắc nhờ bộ phận kỹ thuật chuyển qua cái phần live case của tiến sĩ Trần Hòa và bác sĩ Nguyễn Xuân Vinh.
Bây giờ thành ra hai đứa bay nói tao đứng phụ ngoại thôi, thành ra Hòa cứ nói đi, Hòa cứ nói bình thường thì vậy trong chương trình nó thấy hai đứa thôi. Anh là anh xuất hiện đây là do vụ phèo.